We'll keep it light, given the fact that we are in the holiday season, particularly here in the UK. Um, this will be mainly directed to the residents. I've been told that most of the participants, most of the delegates attending these sessions are residents or radiology trainees. This will be entirely case-based, maximum images and minimum text. So we'll try to analyze the cases. There will be some take-home points, which I hope will be useful for your day-to-day practice and also for your exam, whether it is MD, DNB, FRCR, whatever exam you are aiming to take. There will be nothing too complex about this. A lot of things you probably already know, but we will go through them and try to get these reinforced in our minds. Okay, so without much ado, we straight away go to the first case, which is a 64-year-old female with history of cognitive decline. Um, this has been worsening and lasting for about the last 8 to 12 weeks. No relevant family history as such, and no risk factor for small vessel disease, small vessel ischemia. So I'm just going to scroll through some selected T2-weighted axials and some other sequences. Okay. So these are the T2-weighted axial images. A couple of coronal T2-weighted flare images, and deficient weighted images. You've got the B1000 and the ADC map. And we also have got 3 selected images from the SWI sequence. Okay, so you have seen these images, and we also have the post-contrast images, 3 post-contrast images. So with that in front of you, what did you do next in terms of radiological investigation? So we'll just give you probably 10 seconds or so. Uh, so somebody has asked for a history. So history is of cognitive decline and no relevant history in the past. What would be your next investigation? Anybody? Okay. So what we did, we went straight for a CT angiogram. Okay. Now these are the MIPS from a couple of subtracted angiograms, CT angiogram images. And the reason we went for CT angiogram was due to the fact that we noticed these engorged vessels along the cerebral convexities, along the margins of the cerebral ventricles, particularly along the cerebral convexity. So these are all dilated veins. And also in the SWI images, you've probably already noticed there are dilated veins and also some transmental veins, congested, dilated veins along the cerebral convexities. And similar appearance on the post-contrast images as well. There was no parenchymal pathological enhancement as such, but the veins look very prominent. That made us wonder whether there is any shunting lesion underlying somewhere, and that prompted us to do the CT angiogram. And lo and behold, what's happening here? This is an arterial phase. It is a CT angiogram. But what do we see here? There is opacification of the venous sinuses. So straight sinus, superior sagittal sinus. You don't expect this enhancement in the arterial phase, but unfortunately, this has happened. And this is an oblique view. This is, of course, a lateral view. Oblique view, you see similar appearances. Is there anything else going on here? There you go. So in the occipital region, you see this conglomeration of abnormal looking vessels. And you see the occipital artery is dilated. There are some branches which are quite dilated, some draining veins which are tortuous, dilated, and there is this conglomeration of vessels based along the dura. That's where you would expect the dura along the occipital bone. So this patient went on to have a formal angiogram. This is an image from external carotid injection. And what do we see here? This is the contrast which has just started to go in. And in later phase, you see the similar picture, what we saw on CT angiogram, early filling abnormal filling of the venous sinuses and this abnormal mishmash of vessels in the occipital region. And you can see further venous filling. So this is a dural AV fistula. Somebody has already answered this, which is fantastic. Probably seen similar cases before. That's brilliant. And you can see in the later phase, in the venous phase, there is, of course, as expected, filling of the venous sinuses. And look at this engorged, um, dilated veins along the cerebral convexities. So this is all due to venous congestion. So, dural AV fistula and dementia. Okay, it's rare, but it's an important entity to bear in mind. And the most accepted theory is that, with dural AV fistula, you have raised venous flow. So there is essentially a shunt between the artery and the vein, and there is direct um, uh, shunting of arterial blood into the venous side, and there is arterialization of the veins. There is venous congestion, there is hypertension, and that leads to ischemia. Okay, and this is what we saw initially. But there are, of course, other theories behind the causation of dementia. For example, there is steal phenomena due to the shunting of blood, and therefore, due to reduced perfusion, there is reduced functioning of the areas responsible for memory. This talk is not about dural AV fistula. I'm not going to go into the details, but do remember that dural AV fistulas account for about 10 to 15% of intracranial vascular malformations. And essentially, the dural AV fistulas are shunts between meningeal arteries and intracranial venous systems. And the most common areas involved are the sigmoid sinuses, like we saw in our case, transverse sinus. Also, the transverse sinus was involved in this particular patient, and the cavernous sinuses. Borden classification is one of the classifications used um, for dural AV fistulas, but a more extensive classification is the Coneyard classification. And as part this classification, type 1 and 2A are benign. When I say benign, that they tend to be not aggressive. They don't generally bleed. They usually don't cause neurological deficits, but other types can cause hemorrhage, neurological deficits, and even they're associated with mortality. Dural AV fistulas have a strong association with cerebral venous thrombosis. This is a paper from a few years back where they looked at whether they could establish the association between dural AV fistulas and cerebral venous thrombosis. And in their cohort, 1 out of 3 patients with dural AV fistula had a cerebral venous thrombosis at some point, okay, either initially or during follow-up. And there was a direct anatomical relationship between the dural AV fistula and cerebral venous thrombosis in 82% of cases. So this has a bidirectional association. So which one is the egg, which one is the chicken is difficult to say. So which came first? Okay, whether it is the dural AV fistula, which caused the venous sinus thrombosis, or the venous sinus thrombosis caused the dural AV fistula. It's not always clear, but important point to remember is that there is a strong association. So this patient had embolization. This is the appearance post-treatment, and you can see the cast of the um embolizing material used. Post-treatment angiogram, there is enhancement, filling of the occipital artery and its branches, and you note that there is no early filling of the venous sinuses. And this is the pre-treatment angiogram where we see the early filling of the venuses. So very nicely embolized, satisfactory filling of the shunting. And you can compare the pre and post-treatment MRI as well. So pre-treatment, you can see all this diffuse T2 hyperintense um, changes in the white matter, which we saw earlier, and also the engorgement of the vessels. These have pretty much all resolved post-treatment. So between these two MRI scans, I think there was a gap of about 6 weeks, I think. But very satisfactory outcome. Uh, Moving on, but staying in the same topic, 55-year-old man with cognitive issues and tinnitus. So there was an additional clinical feature this time, which was tinnitus. And like we saw in the previous patient, quite extensive T2 hyperintensity along the white matter, and very much engorged vessels, much more pronounced than what we saw in the previous patient. And in fact, there are changes in the posterior fossa as well, some changes, some T2 hyperintensity, the brainstem. And this patient also had a CT angiogram followed by a formal DSA, a couple of images from the DSA, and you can see the fistulations of the meningeal branches in the sigmoid sinus. And this was the direction of blood flow. So this is not the normal direction of blood flow. This is reflux of blood in the opposite direction. And you can see the enlargement of the engorgement of the vessels. Again, this patient underwent embolization, large balloon put in, and these fistulae were occluded by embolizing material. And this is the post-treatment angiogram. You can see the balloon still there and the cast of the embolic material used. There is no abnormal filling of the venous sinuses, which we saw earlier, and the normal flow has now been restored. So the supraesophageal sinus is fills up first, as expected, then transverse sinus, and eventually the sigmoid sinus. While the sigmoid sinus is still occluded, I think, with the balloon. Okay, so this was the second patient, and you can see on the the post-treatment images, the white matter changes have almost completely resolved. The engorged vessels have also completely vanished. So, what are the take-home points from these two cases? So, look out for dilated engorged vessels. Okay, so when you are reviewing an MRI, see whether you see abnormally dilated vessels. Second point to take home would be dural heavy fistulas can cause white matter changes, and this can be a cause of dementia. Okay, rare, but something important to bear in mind. And if you're evaluating a patient with history of tinnitus, particularly pulsatile tinnitus, definitely, you have to consider dural LV fistula as a cause. Just going to have a look at what people have put on the chat box. Yeah, somebody has mentioned dural LV fistula, fantastic. Another patient, venous hypertension, brilliant. Why diffusion vital changes? Was there true restriction? Very good question. I don't think there was any true restriction. Probably there were a couple of areas which showed a bit of true restriction, but overall, I think it was facilitated uh, restriction. But yeah, there was definitely at least mild degree of diffusion restriction, particularly at a few areas. So maybe recently, when the patient presented, the ischemic changes had progressed and you know caused through diffusion restriction. But thankfully, in post-treatment images, there were no established infarcts. Good for the patient. Let's move on to the next case, which is a 40-year-old male with history of complex partial seizures. Complex partial seizures, okay? And recently, its seizures have worsened, so they have become more frequent. Unfortunately, there was no previous imaging, so this was the first time he was having an MRI. So let's move on and see what the image showed. So T2 weighted axial images. Okay. T2 coronal flare. I think this is the most useful sequence in this particular case. So if you have noticed any abnormality, please type on your chat box. Left temporal region, left temporal hyperintensity, left MTS, amygdala signal. Excellent. Okay, great. So there is indeed abnormality in the left mesial temporal region. This is where um, you, you can see some abnormality. and it's clearly asymmetrical compared to the right side. You have swelling and T2 hyperintensity in the amygdala, not just limited to the amygdala, but also extending to the parahippocampal gyrus and also a bit to the occipitotemporal gyrus. Diffusion weighted images, I don't have the ADC with me, but you have to take my word for it. There was a bit of diffusion restriction. There was a bit of mild diffusion restriction. Patient had contrast. I mean, it was a swollen amygdala, whether it's a tumor. So I think it's quite reasonable to give contrast, and there was no enhancement. So this was the abnormality which we saw anteriorly at the level of the amygdala. But does the story stop there? Let's have a look. So yeah, uh, low-grade glioma was what was initially considered. I think it's very reasonable to consider that. But as we go posteriorly through the hippocampus, what do we see? So the abnormality in the hippocampus is very much obvious there. And you can see the T2 hyperintensity in the left hippocampus. And in addition, you have also got loss of volume. If you compare with the right hippocampus, the left hippocampus is very much shrunk, very much shrunk. Okay. So what's going on here? Any thoughts? So this is hippocampal sclerosis, of course. The changes in the amygdala, does it belong to this particular entity? Okay. So we repeated the scan 6 weeks later, and these were the images, coronal T2 flare. So this was your initial MRI where we saw the swelling and T2 hyperintensity of the amygdala and the adjacent structures. This is all done now. This is the repeat MRI. However, the hippocampal sclerosis, which we saw, as expected, that persisted. Okay. So what do you think is the diagnosis? Seizure-related change. Okay. So the seizure-related change here was adjacent to the causative abnormality. Okay. So the patient has mesial temporal sclerosis or hippocampal sclerosis, and there are changes secondary to the seizure activity, very much close to the um, mesial temporal region. I mean, the mesial temporal sclerosis. So, hippocampal sclerosis with seizure related change. That would be the complete diagnosis. So, this area of hippocampal sclerosis was present on both initial and follow up MRI. Let's move on to the next case. This was a patient who presented with repeated seizures. I think this chap was in his mid 60s, and he presented to a different hospital initially with multiple seizures, which started in the last few days. So this was the initial MRI, and you can see the left frontal lobe being extremely abnormal. You have T2 hyperintensity involving a large area of the left frontal lobe. And post contrast, there are a few foci of enhancement. Okay. There is, of course, mass effect, and it's quite reasonable to consider this to be a transforming glioma, right-weight glioma, given these changes. On the diffusion weighted images, though, you can see the diffusion restriction involving the cortex in the anterior and the medial aspect of the frontal lobe. But this area here doesn't show any diffusion restriction. The enhancement is also limited more to the lateral aspect. Okay. Again, the changes here are limited to the cortex. The white matter is relatively spared, but the abnormality here involves both the gray and white matter. So when I saw these images, first thing which struck me was that there are probably two things going on here. Okay, it's not just one entity. So I asked them to repeat the scan in a few days' time. So this was the initial scan, and of course the seizure needed to be controlled, which they did. And this was the follow-up MRI, and you can see the cortical changes anteriorly and medially in the frontal lobe. They have all resolved. Okay, but the other changes more laterally, they persisted. So when the surgeons went in, they just limited their surgery to the lateral aspect where the tumor was, and the anterior aspect was not touched. So the anterior aspect and the medial aspect of the frontal lobe, the mesial frontal lobe, was left untouched. And the changes which we saw earlier are all related to seizures. Okay, so seizure-related changes can occur anywhere. There are, of course, some specific areas which have the propensity to develop the seizure-related changes. There is another patient with seizure-related changes. This was the initial MRI. You have got the T2 hyperintensity cortical ribbon-like in the lateral temporal lobe, and follow-up MRI, it's typically done. So again, an example of seizure-related change. Here, however, you don't have another abnormality which caused the seizure. So in the first patient, you had the hippocampal sclerosis and the seizure-related change. Second patient, you had the tumor and the seizure-related change. In this particular patient, there was no thing else obvious. This was a case which we had published as a case report somewhere, and this was a young woman. I think she was in her early 30s, and the eagle-eyed amongst you have probably already identified the abnormality, which is here in the left mesial temporal region, and the rest of the brain was completely normal. So on T2 weighted coronal flare, you see the abnormality which you had seen on T2 weighted axial. This involves the parahippocampal and the lingual gyrus, and the rest of the brain was normal. So this patient was being worked up for surgery. This was thought to be a tumor, and this patient was being discussed in our multidisciplinary team meeting, and there was an updated scan done before her surgery, and this was the pre-surgical scan, and something else popped up. So this was an abnormality in the corpus callosum, the splenium of the corpus callosum to be precise, ovoid, T2 hyperintense, much well demarcated. And on the coronal images, you see the initial abnormality which we had seen, and also the T2 hyperintensity in the corpus callosum. And also showed marked avid diffusion restriction. So at this stage, what would you want to do? So the surgeons were keen to take it out. I think somebody has already given the answer. Yeah. Let me just move on to the next slide. So our advice was to optimize the patient's seizure control, optimize the medications, and repeat the scan in a few weeks' time. The patient eventually had a scan a few months down the line, and the splenial lesion had finished. So this is a typical example of reversible splenial lesion. This is a no-touch lesion, often associated with seizure activity, increased seizure activity, anti-epileptic drug toxicity, and there are reports of similar appearances in cerebral infections. You have to consider entities such as stress, extrapontine myelolysis, ischemia, demyelination when you see similar appearances. But in the context of somebody having seizures, somebody on probably multiple anti-epileptic drugs, when you see something like that, leave it alone. Medical management, um, optimization of drugs, optimization of control of the seizures, repeat the scan, and most of the times this will go away. So, take home points from the last three cases. Remember seizure-related changes as an entity. So, when you review a scan in a patient with seizures, what you see may not be the cause of the seizures, rather it may be the result of repeated seizures. They have typical appearances, so usually involves the gray matter, cortical ribbon-like diffusion restriction, and the changes may often be adjacent to the actual cause of the seizures. Okay, and it may therefore become very important to differentiate where the changes are, and demarcate the area where the post seizure changes are from the positive, from the etiology, the causative problem. And it's important for the surgeons to know, like For example, the patient with the tumor and the seizure-related changes we saw in the second example. These changes are said to be due to excitotoxicity, mesial temporal lobe, corpus callosum, thalami, basal ganglia, and cerebellum are the areas which are commonly involved. So remember seizure-related changes, and of course, reversible spinal lesion. A couple of announcements to make. So we organize this BSNR Grand Rounds, the British Society of Neuroradiologists. We organize this Grand Round every month. It's the second Wednesday of every month. UK time, it starts at 12:30. It's for an hour. And like I said, it's second Wednesday of every month. The next one will be on the 14th of January. Dr. Mark from Mayo Clinic will be doing the session, and he'll be presenting some interesting pituitary cases. So you can register. Once you get registered for a session, you can register for all the sessions, and you will keep getting out information about all the future sessions. So BSNR Grand Round, it's a very popular um, learning platform in the UK, and it's been also very popular abroad. Another announcement, the Prime Red is starting the Neuro MRI Fellowship. It's an online fellowship. They had done the MSK Fellowship, which was very, very popular, I believe. And they are doing the MSK Fellowship again. So the Neuro MRI Fellowship will be starting next year. I'm one of the directors, and many of you might know Dr. Professor Tufel Patankar, who is the director for this course. So yeah, please have a look, and I'm hoping to see a lot of you in this fellowship. Okay, moving on. Next case, this is a 50-year-old male with history of seizures again. This guy has history of learning difficulties and long-standing left-sided weakness. There is no previous imaging available again in his case. So let's go through some of the images. So these are the T2-weighted axial images. There is an obvious abnormality in this, but we'll have a look for any other abnormalities. So the T2-weighted axial images, and then you have got the T2-weighted coronal flare images. And you can see there is significant loss of volume um, for the right cerebral hemisphere, particularly involving the posterior frontal lobe and the parietal lobe. And also there is this T2 hyperintensity particularly involving the superior frontal gyrus and superior parietal lobule extending down. There's a bit of prominence of the ventricle due to X vacuodilatation. So this is all gliosis. And in addition, you have got changes in the hippocampus, in the right hippocampus. The right hippocampus looks brighter, and it's also smaller compared to the left. I can see the posterior body and tail of the hippocampus. The posterior body of the hippocampus is smaller than the left. And again, similar appearances uh, on this particular image. And you can see the gliosis in the right cerebral hemisphere. And these are if you select coronal T2 flare images from a volumetric flare sequence, and you can see very nicely the trophy of the right hippocampus. It's almost like a pancake, very much flat. And of course, the changes which we saw in the right cerebral hemisphere. So there is old hemispheric insult, and in addition, there is right hippocampal sclerosis. So we know the patient has history of developmental delay, learning difficulties, and a long-standing left-sided hemiparesis. So this is most likely due to an old insult, maybe in the perinatal period, likely to be ischemic. But in addition, the patient also has right hippocampal sclerosis. So the point I'm trying to make here is that watch out for dual pathologies. So patients may have two existing pathologies. Another case, very obvious abnormality in the left amygdala extending to the hippocampus, multiple small rounded T2 hyperintense lesions almost wholly zinc together, forming one lesion, and also expansion of the amygdala. Um, Many of you might have made the diagnosis already. And on the T2-weighted corneal flare images, you can see the abnormal thickening and T2 hyperintensity. Post contrast, there is not really any area of enhancement. So this is a DNET, giving the typical bubbly appearance of the lesion. No prizes for guessing, often associated with epilepsy, as we know. But again, is that the end of story? If you go to the corneal flare, you'll see that the right temporal lobe, the right hippocampus in particular, there is atrophy, and therefore there is enlargement of the temporal horn of the right lateral ventricle there. And you can see the atrophy in other slices as well. So again, you've got dual pathology. There is atrophy of the right hippocampus with T2 hyperintensity in keeping with right hippocampal sclerosis, and you have got the DNAT. Okay. Another example of dual pathology. And here the changes are on opposite sides. Another patient, this is also a lesion in the right temporal lobe, not in the right mesial temporal lobe. It's more involving the temporal stem and the superior temporal gyrus, more rounded, not giving the typical bubbly appearance we saw in the previous case. T2 hyperintense, maybe, there's a small area of hypointensity centrally. Interestingly, in this particular patient, there was some enhancement of the lesion. But again, is that the end of story? Patient, of course, was, patient had refractory epilepsy on multiple drugs and was being considered for surgery. Patient went on to have surgery of this tumor. But even before that, it's important to review the scan properly and to look for any other abnormality. And the patient did have a left mesial abnormality as well, mesial temporal abnormality in form of hippocampal sclerosis. So you've got a tumor in the right temporal lobe, and also left hippocampal sclerosis. Again, an example of dual pathology, right temporal DNET and left hippocampal sclerosis. These are the postoperative changes. So the tumor was taken out. It was initially thought to be cause of the patient's problems. So this was taken out. And surprisingly, this came as a DNET. It didn't have the typical appearances of a DNET, but the histopathology was of a DNET. So take home points from these cases. Remember, dual pathologies in epilepsy. So if you have seen something obvious, look for the existence of a second pathology. Satisfaction of search, I cannot emphasize enough, is a big enemy for radiologists. So try to curb it, try to kill it, review all the areas, review the scan completely, look at all the sequences to find any other abnormality. And this is very important, particularly in the context of epilepsy, because further surgical management, further electrophysiological investigation will depend on what you have produced as a report, what you have identified. Okay. So if you have identified more than one area of abnormality, and if the patient is being considered for surgery, stereotactic EEG may be performed, or other ways of investigation of the cause of seizures. We'll look for the seizure focus in all the areas which you have identified um, as the possible cause. So, for example, if a patient had mesial temporal sclerosis and, say, focal cortical dysplasia, the electrodes will be placed in both these areas, and EEG assessment, stereotactic EEG assessment will be done accordingly. And then an informed decision can be made about surgery, which area should we go for first, and whether we should leave both areas, or whether surgery should be done in a stepwise manner. First the mesial temporal sclerosis, then the focal cortical dysplasia, or vice versa. So your assessment will determine further stereotactic EEG assessment and surgical management. So these are the take-home points which I have already mentioned from these three cases rather. So let's move on to next case. This is a 30-year-old male with sudden right hemiplegia, no history of trauma. 30-year-old male, sudden right hemiplegia, no history of trauma. Okay. Patient was unable to stay very still, so not great quality images. CT scan showed this large area of hemispheric bleed, and the hemorrhage is extending into the left lateral ventricle. There is significant mass effect. Okay, and there is some edema surrounding the hematoma. So, would you consider any other investigation at this stage? So the neurosurgeon is, oh, sorry, I think I've already given you the answer. But the neurosurgeon is considering evacuation of the hematoma. She is on the line, and angio, CTA, somebody has mentioned CVT, fine. Okay, I mean, they are all correct. So the patient is still on the CT suite, and we go ahead and do a CT angiogram. So these are some selected images from a time-resolved CT angiogram. Okay, let's consider it as a CT angiogram. Okay, nothing fancy. But this patient, because he's young, we were thinking of a shunting lesion, such an AVM. So we went on for a 4D CTA or time-resolved CTA. So these are the images. So you can see the early filling of the arteries. This is obviously an AP view. The arteries filling up, arteries are filled up, and there is an abnormality in the left side, which we have already seen. And there is abnormal filling of contrast, slightly multilobe in the uh, left side, probably in the M3, arising from an M3 branch. Okay. And you can see the rest of the vasculature is abnormal. Sorry, normal. There was no venous sinus thrombosis. So, what is your diagnosis? If you say this is an aneurysm, you're absolutely correct. Okay. But is that it? Is that the final diagnosis? Is there anything atypical about this aneurysm? Yeah, somebody has mentioned this already. Very good. Yeah. So, this is where you would expect the main branch of the circle of Willis. Okay. This aneurysm is miles away from the circle of Willis. This is not where you will find a typical saccular or a berry or a degenerative aneurysm. This is far, far away. Not the typical location of saccular berry aneurysm. And the important bit of history, which I did not give you because I did not get the history initially, was that the patient was treated at our local cardiothoracic center for infective endocarditis. The patient had infective endocarditis involving the valve, and that gave it away. So this is a mycotic aneurysm. And as you know, mycotic aneurysm is an aneurysm arising due to infection affecting the arterial wall, weakening the arterial wall, forming an aneurysm, and they can bleed quite easily. This is what had happened with this patient. Take home points from this case. Remember atypical causes of aneurysm. When you see an aneurysm, identify the location and look at the history. Okay. So not all aneurysms are saccular or berry, particularly, young patients like this, if they have an aneurysm far away. And, atypical causes of aneurysm besides mycotic aneurysm could be secondary to, say, vasculitis. That's an important cause. If textbooks mention about tumors invading um, into vessels causing aneurysms, although I don't know whether I've seen any of those before. Trauma, but these are more pseudoaneurysms rather than true aneurysm. But initially, you may not be able to differentiate between the two. So remember mycotic aneurysms. Next case is a 62-year-old male. He's been having headaches for several months, and this is now worsening. Just two images, one T1 sagittal through the midline, another T2 axial. What do you think is happening? Somebody has said SIH, spine cyst, okay, IIH, venous hypotension or hypertension. Somebody has said, okay, fine. Yeah, these are all classic features of intracranial hypotension. You've seen the sagging cerebellum, the cerebellar um, tonsils are ectopic in a way, and the mammario-pontine distance. So this is the mammillary body, one of the mammillary bodies. Pons, the distance has severely reduced. The pituitary is engorged with the upward margin, convexity of the upward margin, and on the T2 axial, you see the effacement of the perimesencephalic cisterns. The third ventricle is almost slit-like. All typical classic features of um, low pressure. What next? So the patient had other sequences as well, and on the flare you can see diffuse thickening T2 hyperintensity of the dura. Post contrast, there is smooth enhancement of the dural along the convexities. So typical features of intracranial hypotension. Many of you have already made the diagnosis. So, what would be the next investigation? Okay, at this stage. Now, just to let you know, this patient has no history of trauma. There is no history of rhinorrhea, CSF rhinorrhea, no history of um, autouria, CSF autouria, but no significant past medical history as such. This is the first time the patient has presented. So next investigation, as you have already mentioned, some of you have already submitted it on the chat box. The next investigation should be looking at the whole spine. The patient had MRI of the whole spine. These are some of the STEER images, and there was no abnormality detected. And just checking on the chat box to see what people are saying about spinal imaging. Yeah, somebody has said spinal imaging, and somebody has mentioned Slack, which is a collection. So basically, we are looking for collection within the spinal canal, and I don't see any. There's no spinal collection, at least in this patient. So, what would you do next? What is your uh, strategy? Somebody has mentioned tethering with Chiari malformation. No, it's not Chiari malformation. DSA, myelogram, CT myelogram. Okay. Um, Would you just do a standard CT myelogram? Anything special about the myelogram? So for the radiological investigation, you could go for a radiological investigation, fantastic. But in many places, people may just go for a blind epidural patch. Okay, they might send the patient for an epidural patch of injection of blood patch in the epidural space. And in a lot of cases, the patients get treated and they don't need any further investigation. Okay, end of story. But this is what we follow in our center. Patients usually go for a blind blood patch, and if it treats the patient, then that's it. But if it doesn't treat the patient, then we call the patient for a dynamic CT myelogram. Now, dynamic CT myelogram is different from a standard CT myelogram. Dynamic CT myelogram, it implies that, as the name suggests, it's dynamic. So you inject the contrast and you immediately scan the patient and you look for any leak. Okay. So the patient which we discussed came for a dynamic CT myelogram. There was no intraspinal collection. So in patients who do not have intraspinal collections, we start by doing the myelogram in the lateral decubitus position. And you can see the patient is in lateral decubitus position. We did the lumbar puncture and we did inject the contrast. You can see the contrast which has collected at the redundant part of the thecal sac. And what else do we see? So see some contrast outside the thecal sac in the paravertebral region. Okay, and it's filling up the paravertebral veins. So there is enhancement of the paraspinal veins. And what does that imply? What is the diagnosis? Let's check whether anybody has. Yeah, fantastic. A lot of people have come up with the answer. This is the typical appearance of a CSF venous fistula. Okay, so there is a communication between the subarachnoid space, the CSF, into the paravertebral venous plexus. Okay, so this is CSF venous fistula, and this is considered to be a type 3 leak. Um, and you can see where the communication arises from. Now, people can either do a CT, dynamic CT myelogram, or dynamic subtraction myelography, DSM. Um, you can choose whatever you want. Both these have their advantages and disadvantages. It also depends on availability. We generally go for CT myelogram first, at least. You can consider the second modality to be a problem solving tool. There is nothing, I think, clearly right or wrong about what you want to choose. So, this is from a DSM. These images are from DSM, dynamic subtraction myelography, and you can see the filling of the veins, paravertebral veins. And this is what we are looking for, the hyperdense paraspinal vein. And as we saw in our case, this is from a journal, and you can see filling of the paraspinal vein after injection of contrast into the thecal sac. So this is on CT, this is on myelography. Another patient with similar history, the MRI brain. I've not shown you the images of the MRI brain. They had typical appearances of low pressure, but what do we see here? So the spinal imaging is not normal. Okay, you do have oops, intraspinal collections, and where is the collection? Is in the epidural space. Okay, so you can see dura, the dural lining, and there's this collection. Again, posteriorly, you've got this collection, and that's the dura pushed anteriorly. Okay, this is all intraspinal collection. So this is a spinal longitudinal epidural collection. And if we see something like that in a patient with spontaneous intracranial hypotension, we do the CT myelogram in the prone position. So again, this patient could go for a blind patch, and that could just treat the leak and end of story. But if it doesn't treat the patient, then we go for a dynamic myelogram, and we would start by injecting the contrast in the prone position. And as you can see, lumbar puncture, injection of contrast into the thecal sac filled up with contrast there. And you can actually see collection of abnormally located contrast. So there is epidural collection here, and you can see a defect in the dura where the subarachnoid contrast is going into the epidural space. So that's where the tear is, the dural tear is. And when you look at the sagittal images, you can see the collection, epidural collection of contrast, the abnormal pooling of the contrast anteriorly in the epidural space. And that actually corresponds to this osteophytic bar. Okay, there is a disc osteophyte bar here, which we can now say with a good degree of confidence is the cause of the dural tear. So treatment-wise, one could go for a blood patch directly at this level. This may or may not treat the cause, but the definitive treatment would be actually taking this osteophytic bar off and sealing the dura, repairing the dura at this level. Let's have a look at the chat box and see what people have said. How much time do we need to wait and scan post spinal injection to demonstrate leaks? Do it as soon as possible. So, um, the way we do it, we prepare everything. All the planning is done, inject the contrast, and scan is done almost immediately. Um, Sir, can you describe technique of dynamic CTM contrast dose? I generally use say 8 to 10 ml first time, and like I said, inject and scan almost immediately. Should I need to know the level of tear before epidural blood patch? No, if you're doing a blind blood patch, of course, it's blind. You don't need to know the level. You can use it, generally, my colleagues, when they do it, in my department, in my hospital, the blood patches are done by the pain guys, the pain team. So they do it at the upper lumbar or lower thoracic level. Um, that's what they choose for doing blind blood patches. But once we have identified the level, they would try to go and do the blood patch at that level. Okay. In which lateral decubitus it's done right to left? We start with left and then move on to the right. Like the first patient we showed you with the CSF venous fistula, um, we started with the patient lying on their left side, and it was identified on the first run. But for completion, we also did the right side. Um, Somebody has asked for the first case once more. Okay, fine. Let me see how we are doing with time. I think we are not too bad. So first case, let me see if I can go back. Um, yeah, so patient with low pressure, typical appearances. There was no slack, there was no spinal collection, and then the patient. Actually, this patient did have a blind patch, and the patient continued to have symptoms. We wouldn't have done a dynamic CT myelogram if the patient had not had a blood patch, blind blood patch. So, and this was the lumbar puncture at L3, L4 level, injection of contrast, and immediately after the injection of contrast into the thecal sac, the first run, whole spine CT showed this abnormal filling of the veins, demonstrating the CSF venous fistula. Okay. And this is a type 1 leak with slack. So there are two main types. One is due to the epidural leak, the dural leak leading to the epidural collection of CSF. And then you have the second type, which is the CSF venous fistula. And then you have got a third type, which is actually subdivided into two types, where there is a tear in the far lateral aspect of the um, dura, or even further externally at the level of the ganglion. Um, and these may be associated with meningoceles, the nerve perineural cysts. So these are the other two types. You can have a read through this particular article. It's slightly old, but I think it gives a good idea of the different types of leaks and their the associated anatomical abnormalities. I think this is the last case, and staying on to the theme of spinal collections, intraspinal collections. This is a patient with back pain, a weakness in all limbs, and he also had raised white cell count, and the CRP was also quite raised. This was done at another hospital, and initially, when it was evaluated, the report said that there were degenerative changes only, nothing else was reported, unfortunately. But if you look at it closely, so this is T2, this is T1, this is T2, this is T1, okay? Slightly different slices. And you will be able to appreciate that there is actually a large, long epidural collection. So this is on this particular image, and the other images also show the collection. So this is the collection, epidural collection, and you can see the dura has been pushed anteriorly. And also the collection is not entirely that of simple fluid. There are some patchy areas of T1 hyperintensity. Okay, so this is the fluid signal which is pushing the cord anteriorly. Okay, So I think what might have happened in the other hospital where it was evaluated, they might have thought that this is epidural fat, but clearly it's not epidural fat. Okay, so this is T2 bright, and on T1 it is mostly hypointense. So this is fluid, may not be simple fluid because there are some patchy areas of T1 hyperintensity, but this is clearly not fat. Okay, and then the patient had a post-contrast scan, and you can see the collection here very nicely because the collection is now demarcated by quite avid enhancement of the dura. Okay, so there is enhancement of the margins of the collection. You can see the enhancement of the collection, enhancement of the collection. Okay, so there is infection. Okay, um, uh, patient has got very high white cell count and CRP, and so the question is whether where is the collection coming from? And if you look at the discs, well, I've not shown you all the discs, but there was no sign of spondylodiscitis. Okay, so the discs did show some degenerative changes, like we see here in the cervicothoracic junction, lower cervical region, but there was no good going evidence of spondylodiscitis as such. However, when we looked to the cervical spine, we of course saw the collection, the epidural collection, but look at the facet joint. Okay, the right facet joint, there are extensive changes with marked edema in the surrounding muscle. There is fluid in the facet joint, there is T2 hyperintensity, and there is collection surrounding the facet joint. So this is septic facet joint infection. Okay. So when you think of spinal infection, it's not always just discitis or spondylodiscitis. Yeah, spondylodiscitis is the typical presentation, and which you come across day in and day out, resulting in epidural and paraspinal abscesses. But the epidural and paraspinal abscesses may be purely just due to facet joint infection. Okay. Some people call it facetitis. I'm not sure whether it is a legit term. Maybe we can make it popular, but remember facet joint infection. So facet joint infection may be present with spondylodiscitis, and that can cause epidural paraspinal abscess. And there may be pure intradural infection abscesses, which are much more rare. Okay, so the take home points from the last few cases would be spontaneous intracranial hypotension. Remember the radiological features, the intracranial features, and how to investigate further. Recognize interspinal collections. Okay, maybe easy to miss, particularly if the technique and the quality of the scan is not great, then it is very easy to miss. So if you see something inside the spinal canal, is it epidural fat or is it fluid? That's very important to identify. I think I'll stop there. We have pretty much run out of time. Um, I have probably addressed a few questions as we went along, but if you have any further questions, feel free. We may have a couple of minutes, but